Today we're very fortunate to have Dr. Calum with us to present on redefining diseases for a digital age. Dr. MacRae is the Chief of Cardiovascular Medicine at Brigham and Women's Hospital and an expert member of their Cardiovascular Genetics program. He's a leading investigator at the Brigham and Women's Genomics Center and an associate professor of medicine at Harvard Medical School. Dr. MacRae completed his medical degree from the University of Edinburgh College of Medicine. He went on to complete 2 internal medicine residencies, one at Wellcome Trust Center for Neuroimaging in London, and the other at Brigham and Women's Hospital. He then completed a fellowship in cardiovascular disease at Massachusetts General Hospital, followed by postdoctoral fellowships in both human genetics and developmental biology. His research focuses on the biology and genomics of cardiovascular disease, and his clinical interests include investigating new cardiovascular phenotypes and determining how genomic discoveries can be systematically implemented into clinical care. Please join me in welcoming Dr. MacRae.
Thank you. Well, it's an honor and pleasure to be here. I, as you can tell, have had a fairly checkered past. And so referred to in at least one NIH pink sheet as hopelessly unfocused. And what I'm going to try and do today is show you some of the stuff that we've been doing since I became Chief of Cardiology to try and essentially bring my life together, but more importantly to try and integrate what we're doing in discovery with clinical care. And I think what I'd like to convince you of in the next 40 minutes is that most of the problems in implementing genomics and changing the way that we do clinical trials and in fundamental discovery are a function of what actually we measure in patients. And then until we change that, we're going to end up with exactly the same results as we've had over the last 25 or 30 years. I have some disclosures. At the start, as you can see, a few patents. I'm not going to, there's one zebrafish slide, so don't worry. These are my industrial disclosures. This is probably the most important one because it's the largest. And then the really important one is academic self-interest, which is the one that you can't measure. Every other self-interest has a financial value attributed to it, but I think one of the things we don't really recognize in academic medicine is just how much of what we do is polarized as a result of the fact that we have to make a living. What I thought I'd start off with is really thinking about competing visions. We hear a huge amount in the press, in the medical literature, and also in terms of our day-to-day work about trying to implement precision medicine. And I took this off Bayer's website, but any self-respecting pharmaceutical company on the planet has something that looks like this, changing the game from a drug that's given to everybody, some of whom have a salutary effect, some have no effect, and some of whom have adverse effects, and changing this to precision medicine. That's the latest incarnation of it. But I have to tell you, when I was a resident in Edinburgh in 1985, this was exactly what people said they were going to be doing. And the sad thing is it's now, I hate to think about it, but almost 30 plus years later, and we're still doing the same thing, although we've changed the name at least a couple of times. The other thing that's happening, and it's hard to escape this if you're in clinical medicine, and I know this is actually a focus of an amazing amount of activity here. I feel like I'm in many ways taking coals to Newcastle, is this investment in technology. But yet, again, despite the fact that we've said we're going to try and do this, we're going to change care delivery, in almost every instance, that has actually failed to deliver the benefits that we would have hoped. And in fact, this is a slide from Forbes showing that plugging new technologies, and this is their title, into old business models has actually caused healthcare costs to rise rather than fall. And any of you who have spent even 20 minutes working with a new EHR will realize it's the only situation in your lives where electronic digital technologies actually increase the work to for the end user. There's no other setting on the planet where that would be tolerated. So why is it that we've ended up in this mess? And what is it that really is at the core of these problems? This is another example of exactly how we've ended up distorting what I believe we need to be doing. This is actually from the federal government from May of this year. So this is their description of what a learning health system would look like. And what you see here is essentially what I think is part of the problem. which is that we have focused not on centering it around patients and patient biology, but actually on the existing structures. We've sort of digitized, we've bolted digital technology onto an 18th century business model. And you can see all of these illustrated here. Simply the addition of 2 arrows is enough to change something in our minds from an 18th century organization to something that's ready for prime time. And at the same time as all of this is happening, a lot of the early efforts, whether it's AI or even, as I mentioned a second ago, the decentralization of medical care, have all begun to flounder a little bit. I don't think they're going to flounder completely for the reasons that I hope to show you, but ultimately they have failed to make the incremental changes or transformational changes that we had hoped. In fact, the first and second generation remote telemedicine efforts in heart failure have uniformly failed. This is one of 6 clinical trials. Akshay Desai, who is actually a faculty member with us, did one of the original trials about 8 years before this one was published in 2011. This was the first of a tranche of about, well, I said 6 of them now, where people built what they thought was a state-of-the-art remote monitoring platform. They essentially used it to look at about 700 high-risk heart failure patients, and the outcomes were, no matter how you dice them, were essentially no different from the standard of care. And in fact, one of the things that's probably worth pointing out is, again, this is itself a slightly incremental model from what has been done before. We'll get back to what I think are the core problems with this model in a few minutes. So what's basically wrong with current disease definitions? Well, they're largely expectant. This is a graph that comes up a couple of times. This is one of the best things about this field, is you can actually make up axes on your graphs. This is health, this is disease, this is birth, and this is death. And it shows you how little information is actually present in the field. And I've coded health and wellness in green, this sort of transition in amber, and then red as the disease entity. And essentially almost everything that modern medicine does is focused on this time point here, where essentially a patient shows up with a problem and we then begin to try and solve it. There are massively evolving treatment guidelines, which, to be honest, take somewhere between 12 and 15 years to reach equilibrium in the population, despite the fact that every other industry on the planet is able to implement changes almost overnight. We take 12 to 15 years. And that gives you a clue as to what some of the core problems are in all of this. So just as an illustration, if something can be protocolized to a guideline, should that still be a professional endeavor? So that's the first point that I think is worth really highlighting here. The other thing that's worth noting is that essentially once the diagnosis is made, everything else is really in free fall. You're going through a series of iterations, but there's very little in terms of measuring disease process or progress, and there's almost nothing, except actually I have to say in cardiology, a plug for cardiology, ever happened in the pre-disease setting. And there I think cardiology actually has made some efforts based on biomarkers such as LDL, but in a very narrow setting. What we haven't really been able to do is move the needle back to this deviation from health, or importantly, the maintenance of wellness. So current disease definitions actually prevent delivery system evolution. They're all analog, they're sort of cross-sectional, single time point. There's almost no information on what's really happening. And most of what we do is defined not by the disease trajectory, but actually by the therapeutic trajectory. There are inadequate data to identify patients at the correct point in a therapeutic trajectory. So there's a huge industry. This is actually one of the reasons that I actually started working in this space, is the Brigham and Women's Hospital Cardiology Division makes 5 times as much money from clinical trials as it does from clinical care. And so if I look at our business model, if we don't find a way to change the system from one where we have to set up a clinical trial, identify where patients are at the correct point, do the clinical trial, and then wind down the entire infrastructure, we're not going to be able to afford to stay in the game. There's very limited real-world data or experience. There's learned patient and provider behavior. So we have trained our patients to actually love to come back here, to love to measure things that don't make any difference, like follow-up LDL. So secondary LDL, no data that that's actually worth measuring. That's a $200 million a year business in the US. In addition to this, there's almost no validation of any implementation infrastructure, data, or process. And all of this takes place in the context of really quite remarkable regulatory hurdles. So we then, as you have recently, began to think about this in the context of the electronic health records. There were a couple of things that I think I learned in the last 2 years as we implemented EPIC. Luckily, I wasn't paying the bill. It was about $2 billion for us to introduce it across MGH and the Brigham. The first thing that's obvious is it's only a small part of the transformation that's necessary, that we haven't redesigned our workflow, and most of what we've done with EHRs is just implement billing strategies in a computational platform. Data acquisition is obviously very, very much the rate limiting step, and most of the data that are in the electronic health record are really not worth having. I don't even care what I thought a week ago if you need natural language processing to extract it. Most of this is actually a function of the dependence on it being provider-based data entry. We have to change that as a start. And then the other thing that's important is that we have purely transactional interactions. There's no biology really entered into the system in any meaningful way. We can measure potassium, we can measure acid-base status, but unless we know what's happening around the patient, it doesn't really give us any useful biological insights. And the major challenges that we've recognized are standardization, data management and visualization. Already the way that you manage clinical decision support is too complicated to use the electronic health record to display it. What we need is much more intuitive understanding of how the data that we're collecting will be implemented around patient care. And actually the other thing that's probably quite noticeable to any of you who work in this space is that the EHR is collecting the data in a way that actually ultimately make them the providers of the electronic health record are competitors. In the research setting, I think we learned a little bit additional information. First of all, the research community actually was one of the most powerful things driving EHR implementation standardization across the enterprise in the Harvard system. And that single system actually has had the ability to bring people together, for example, across the Brigham and the General in ways that had not happened in the previous 130 years. Investigation, I think, is an important method for system transformation. We've been able to get several 100,000 subjects enrolled within the record, but even then we're just scratching the surface. And the most important thing I think that we've recognized is that having a scalable enterprise but still having individual creativity is very, very difficult in an academic setting. And I think this is probably the second point that's worth making, particularly to this audience, is that we need to rethink exactly how we build teams in academic medicine if we're going to really leverage clinical care and discovery together. And then I think the saddest thing that probably everybody will recognize fairly quickly is that we can't afford to have a parallel research infrastructure. There isn't going to be a second system where all the research data are kept in seclusion, that we're going to have to fully integrate these things financially, intellectually, and strategically. And so this summary slide is probably the single most important insight, I think, is that in every sphere of what we're doing, whether it's traditional genetics, whole genomes in the clinic, clinical trials, or care redesign for remote system-based approaches, the fundamental problem is the information content, that we're collecting the same stuff we used to collect. We're doing it in a very analog and poorly stratified fashion. And then unless we think differently about how we collect information, we're going to get into real trouble. So the best example of this is probably in genetics, where I've spent 3 decades, 2 decades at least, identifying rare alleles in Mendelian disorders. There's been a huge effort where we invested probably $10 billion to do genome-wide association studies. And these are perfectly laudable goals. I spent most of my life doing these things. But the reality is, and we've known this from the start, that most of the real information is in the middle. It's things that we either don't measure, so we can't possibly understand whether they're genetic or non-genetic, or it's things that have a major conditioning variable that we don't measure. The only conditioning variables we actually measure in medicine are alcohol and tobacco, and we do those by report. So it's hardly surprising in a disorder, let's say like dilated cardiomyopathy, that we never really see large families because we're assuming that the final phenotype, the thing that shows up for us in clinic in year 45 is actually the underlying trait that's inherited, rather than a susceptibility to develop some abnormal physiology in the context of some stress that we haven't identified. And so that same problem exists whether it's in clinical genomics, where you can identify 5, 6 genotypes in any individual, but you don't know mechanistically what's underlying the disease, in clinical trials where we haven't really stratified anybody in any meaningful way, or in care redesign where measuring the same stuff digitally doesn't really help you. You can measure the things you measure in an ICU in a home, and it won't tell you any more information than you'll actually need to know. So almost everything is aggregate. There's unidimensional data with no organizing metadata. And as I mentioned, none of the conditioning variables are ever added. So this is the actual gap. When we started the Undiagnosed Diseases program, one of the things, this is a national NIH-funded program. I'm the clinical lead in the Harvard system. The first thing we had to do was to add up all the clinical phenotypes so that we'd understand what the NIH might be liable for if we were to send them the bill. And it turns out if you add every single thing that's ever been measured in clinical medicine, including 60 different diastolic dysfunction parameters, plus all the preclinical phenotypes, it comes up to about 9,800 individual parameters. And so it's hardly surprising that you can't deconvolute a genome at 10 to the 9, a transcriptome at 10 to the 16, a proteome, a connectome, or a physiome, where it's all happening at different timescales. If you're only really measuring 10 to the 4 things, and most of those things are redundant, semi-subjective, and legacy phenotypes in many ways. In addition to this, you'll notice I didn't put anything on the exposure front because I don't think we really have even identified the scale of what's possible. The other thing that's worth pointing out, I think, is that of all these data sets, the only one that we know the boundaries for is the genome. Every other data set is essentially completely unbounded and in many ways untapped. And so we have to, I believe, move completely beyond these legacy phenotypes in order to be able to make some sense of it. This is an image from our version of EPIC, where we studiously, in the 11 minutes that we have with each patient, spend 7 of them entering unstructured 18th century semi-subjective duplicative data that we haven't standardized. And we do it in a way where we don't collect any meaningful additional metadata. So there's a high threshold for any innovation in this space because the actual entry information is the rate limiting step. So it doesn't matter what you do, it doesn't matter how you build your apps, it doesn't matter what information you record, you're still not going to be able to extract any more information from the system that we already have. So this is a sort of archetypal example, glycosuria. Diabetes essentially originally defined on the basis of tasting sweet urine. We've known for almost 15 years that there are amino acid metabolism abnormalities that antedate any glucose abnormality by 15 years, but because of the fact that the entire infrastructure is based around treating glucose, not the amino acid abnormalities, we can't move forward. So you can parse diabetes in lots of different ways. For example, my favorite example here is if you add shoe size and height to the diabetes diagnosis, it turns out you can pull out 4 or 5 of the 12 Mendelian forms just simply because they're growth disorders that are gigantisms or dwarfisms. But do we ever measure shoe size? That actually, believe it or not, is one of the few standardized variables on the planet. There are only 2. This is another thing that's probably worth actually pointing out. And I do, at this point, usually try and ask people by the end of my rambling remarks to come up with any standardized, globally standardized clinical phenotypes other than the 12-lead electrocardiogram or the international normalized ratio. If you can find another one by the end of the talk, I'll give you money. But I think we actually need to build a system that allows us to take these essentially legacy phenotypes and map them onto modern biology. The other thing that we need to do, and you see these diagrams in every self-respecting talk, is begin to integrate all the information. But we've never really thought about how we're going to do that. What are the things you require to relate a genotype to a clinical phenotype? Well, you need to know a lot of dynamic interactions between all of the component contributors, and we've not really built any system that allows us to integrate all the way across these data sets. We have no reference points that you might see, for example, in a geospatial data set. And in fact, integration across these scales requires new data and new tools. And I believe we actually have to make some active choices between breadth and depth. The one thing, and I firmly believe this, that's going to be quite important, and I'll show you in the last few slides why I think it is actually linking clinical and basic science. Genotype allows you to take everything from a plant biology up to the clinical care and relate the two processes to each other. But there are almost no phenotypes that cross from basic science into the clinic. And that's actually a fundamental flaw, I believe, in our ability to integrate. And we also need perturbations that allow us to challenge the system. So there are very few things where we actually push the biology in any meaningful way in our patients or in our animal models. And of course, one of the obvious things here is it's going to be small molecules or biophysical challenges. Those are the only things that operate across a scale from a molecule to a population. Drugs are obviously a very important piece of this. Do we ever record drug responses? Almost never. Why is it that we are giving all of this perturbation to the system, but we haven't built a platform that actually allows us to collect the information we need from that system? So I believe we need a shared phenotypic lexicon that integrates all of this with some mechanistic phenotypes in all species, and ideally allowing us to model co-clinically in real time. What do I mean by co-clinical modeling? This is, as I said, the one zebrafish slide. So we, many years ago, now started modeling a lot of different cardiovascular disorders in the zebrafish. Most of my work is in developmental biology or in high-throughput chemical screening. And we modeled this disorder. This was the first one we did, Naxos syndrome, which for those of you who are not cardiologists is arrhythmogenic right ventricular cardiomyopathy in the context of palmoplantar keratoderma and curly hair. And as we were modeling it, we actually identified very quickly in the zebrafish. Remember, the zebrafish also doesn't have a right ventricle. So we thought that was actually one of the biggest challenges. But the nice thing is that the biology is completely conserved, that all of these disorders are a function of mutations in desmosomes. And we knew that desmosomes were present even in primitive multicellular organisms. We quickly found that sodium channel, this is the wild type, and this is the mutant, was dramatically reduced at the membrane in these hearts. And in fact, it turns out not only in their hearts, but also in almost every other cell in their bodies in certain locations in the membrane. So we actually took a zebrafish, made it genetically identical to the patients, and we were able actually to see this is what zebrafish ARVC looks like. You can see the heart failure even with the naked eye. Nice chubby fish. Here's a thin asthenic fish with a nasty disorganized ventricle. We then built a platform to actually do chemical screening. You just plate the zebrafish into 96 well plates, and we identified a molecule very quickly that actually rescues the mutant phenotype, restores sodium conductance to about 75–80% of normal. When we saw this, we realized if this is happening in every cell in the fish, maybe it's happening in every cell in the human. So we went back to humans and we started to stratify cardiomyopathy based on simple electrophysiologic parameters. So not all of these work, as you can tell, but we don't measure most of these things in most patients. So this is stratification. This doesn't project it very well, I'm afraid. It's a little bit blurred, but this is, as you might expect, skin conductance in amyloid forms of LVH, dramatically abnormal. But actually, there's some interesting things that allow you to begin to discriminate. So skin conductance is abnormal both in AL and TTR amyloid, but auditory evoked responses are only abnormal in TTR amyloid. So within a couple of minutes of coming into the clinic with an LV mass, you can begin to dissociate different forms of clinical syndrome. The other things that you start to see are dramatic parsing of different forms of heart failure. So this is inherited heart failure. This is ischemic heart failure. So there are very profound abnormalities in gait in ischemic heart failure. I actually anticipated it would be the opposite way around. And so by simply changing the phenotypic spectrum, you can begin to parse out in real time some of the physiology. But it gets much better than that even. So when you start to look at a cellular level, if you actually take the individual membrane biological abnormalities and you begin to interrogate those in patients, you can actually take buccal smears from patients with ARVC and identify the cellular abnormalities. So there are junctional redistribution of plakoglobin and connexin 43. This is without treatment. This is with the treatment. So we were able even to test the drug on a cover slip with cells from a buccal smear. And you can extend this. This is not just one disease. This is laminopathy, where in peripheral leukocytes, you can begin to see nuclear blabbing abnormalities that correlate very well with the electrocardiographic features. And in fact, when you go to non-lamin cardiomyopathies and you look for the blabbing, it correlates with AV block for reasons that we don't fully understand. So what we thought as we began to see this was, is there a way of taking known biology and moving it earlier and earlier into the clinic. So this was the sort of a diagram we built really just to show that most of what we're looking at in biology, in medicine, is actually quite late manifestations of the same syndrome. So blood glucose, lipids, diagnostic testing is all really late in disease, partly because of the fact that that's when the patients show up. And what we really need to think about are the very earliest steps in the disease process and ways to build assays that actually allow us to identify the cell biology before it gets confounded by final common pathways. A great example of this is probably coronary disease, and we were recently funded to actually explore this directly. Most of what we work on in coronary disease is actually in this phase, from the lipid-rich plaque all the way through to plaque rupture and coronary obstruction. But it turns out that this is probably the last 15 to 20 years of the disorder. That most of the early biology actually occurs 20, 30, 40 years before this. And in fact, we've known since the Vietnam War that there are abnormalities of aortic endothelium in teenagers with atherosclerosis. But we haven't built any tools that allow us to identify this. And so the goal of this program would be to take generic pre-coronary disease, to identify using much higher resolution cell biological assays, different underlying forms of it in deep phenotyping, then to create superficial assays, things that could be scaled, to allow us to do that at scale in the whole population, and then begin to think about how you can stratify not just disease therapy, but also the underlying biology and hopefully identify new pathways for coronary disease. Is this possible? Well, it's actually worth thinking about what we know about coronary disease as an example. So early clinical pre-phenotypes are actually, I think, very important in coronary disease, because most of the studies that have ever been done in coronary disease, the control group is contaminated by about 30% of the individuals having occult coronary disease that hasn't yet presented. In addition to this, there are very discrete genetics. So these are the known major Mendelian forms of the core genes. If you put those genes into a Drosophila network, so this is fly, wing morphology. I thought Bruce was in the audience earlier. If you put those three genes in, you can predict, first of all, this entire network of interactions. But importantly, you would predict immediately that the same biology would be important for hypertension, because the renin-angiotensin system is a downstream receptor in this pathway. Type 2 diabetes, because the genes that cause type 2 diabetes are also in the same network. TCF7, several other important diabetic genes. And cognitive decline, because even in the fly, these pathways are important for synaptic remodeling and synapse formation. Finally, it is worth pointing out that there are at least 4 phenotypes that we've known for many years are much more penetrant in coronary disease than the actual obstruction itself. So there's retinal patterning abnormalities, skin abnormalities of cholesterol. We wait until the cholesterol is visible to the naked eye as a xanthelasmata or xanthoma, rather than actually trying to detect it in the skin. The statin response itself is actually much more predictive of long-term biological outcomes than any other factor in coronary disease, including coronary angiography. And then finally, vasomotor abnormalities were identified in the late 80s in the teenage relatives of those with coronary disease, but we've never really built tools that allow us to assay that in real time. And so what we've begun to do is to build scalability by design, as I mentioned, to try and take not just these physiologic assays and not just implement them in a wearable fashion, but actually to build cell biological tools that match a perturbation with the physiologic endpoint, in an effort to try and develop a generalized approach to phenotype discovery, to getting new assays into the clinic. And many of these are assays that already exist in model organism biology or in cell biology that we have just failed to move into the clinic. And so we built this sort of overarching strategy where we try and understand not just the phenotype, but also the perturbation, match those things all the way through from cells to the whole organism, validate this in families and in genotype cohorts, and then using this, identify new causal pathways, and ultimately, if we can scale some of this, move it much, much earlier into the clinic and democratize the way that we think about phenotyping. We've built this actually as a sort of pipeline through a relationship between us and MIT, where we take assays from basic science, we move it into the MIT platform to fabricate new assays, to prototype those assays, and then to test them. We bring them back to the clinic, and then we move with other partners to scale these. Ultimately, the actual phenotypes are quite interesting. We've started working on phenotypes, for example, that patients report. So patients report, if you have a family history of hypercholesterolemia, you actually have a very different set of perceptions of what the disease is than we do as clinicians. So we've begun to try and do that at scale. And then finally, what we've thought about is how do we put this all together in a system that actually works for clinical care. So we've looked at what actually doesn't work, and what doesn't work is bolting things together with digitization. What also doesn't work is this platform, and the main reason it doesn't really add value is actually very easy to identify. It's actually the fact that we've built an automated system, but we still have all these costs in the system. And it turns out the biggest problem, I believe, with most of true implementation science is getting rid of the physicians in the places where you can actually get rid of them. And so what we've done is begun to think about how we can do exactly that. The other thing that's worth thinking about as you build systems for implementation is looking at what are we designing the system for and who are we designing it for. So this is from 2015, and you can see that while people over the age of 65 are quite comfortable, again, this is badly blurred, I'm afraid, quite comfortable using digital technology to email their physicians, they're very much less comfortable using even text messaging or video, far less new devices. And in fact, only a very small proportion of those over the age of 65, and it drops off precipitously over the age of 75, are comfortable, are confident using new electronic devices. And these are data from our own clinic, where you can see that over even 4 or 5 years, there was very little change in the uptake of new technologies, simply because of the fact that elderly individuals are not very comfortable moving forward with new technologies. They actually prefer personal contact. So what we thought we had to do was to build a system that implemented digital technology but still retained some personal interaction. And it turns out that personal interaction I don't think has to be a physician. It can be almost anybody in the system. And the more that you drive down the cost of the personal interaction, the more the value of simple digital tools begins to be realized. But importantly, what that also lets you do is actually collect information before everybody in the population is digitally competent. And so what we've begun to do is to build using new data sources, the response dynamics to drugs, real-time stratification and optimization of the whole system by collecting data more granularly, collecting it in the context of a perturbation, whether it's nutritional or pharmacological, in an effort to try and build a platform that actually learns what are the responses. And you would say, well, what does that mean in real terms? How have you possibly done that when none of the new data collection tools exist? Well, it turns out the data collection tools do exist. You just need to know what you're actually measuring. And many of these things, we have sort of had a very preconceived notion of what the data we should be collecting actually are. So on the inpatient side, this is actually quite a good example. You know, we've spent a lot of time, as I'm sure you have, worrying about EHR, waveform data, patient-reported outcome measures. It turns out the most important data are actually things that are coming from the rest of the system. So in fact, there's at least 2 of the heart failure clinical trials have shown that social connectivity is the best predictor of readmission, way better than any of the physiologic data that we actually use. And it can go in either direction. It's actually like terrorist chatter. You don't need to know what's going on, you just need to know what the baseline is, and the chatter will either go down or it'll go up. And that's actually a much better predictor of readmission than most things. Turns out this actually works even in the inpatient setting, as do things like false alarm prediction based on the number of times the lights go on and off in the room. Those are actually very good predictors, much better than any of the data from the electrocardiogram or from the O2 sat monitor, any of those, of what actually is going to be a true alarm versus a false alarm. And so what we've begun to do is actually build our entire data collection infrastructure, not just around trying to find new physiologic measurements or cell biologic measurements, but actually just collecting information on interactions, on the way in which the system works, on clicks per patient. Those types of things turn out to be very important. The clinical transitions are the best place to test them because there you actually have A/B testing in a very real-time format. It allows you to implement things quickly because you're actually saving costs. You don't need to prove that you've changed the outcomes in any meaningful way. And we're already using it for inpatient acuity, for code calls, and for discharge readmission cycles. We did a deep dive on all the data in the EHR, and essentially the day you go home, your data are indistinguishable from the day you're readmitted. It's just which side of the fence you're on. Those are the only two things that actually predict whether you're going home or coming in. And the sad thing is that tells you just how little information is present in the current data sets that we collect. In the outpatient setting, what we've done is actually build a series of outpatient implementation platforms that use AI to identify where you are in your treatment cycle. Then build an algorithm that you can actually use behind the wall. You don't need to be digitally capable. You can actually use a college-trained or even a high school-trained navigator to work with the patient using this algorithm behind the wall. And then we actually have built-in patient support. We have navigators, pharmacists, RNs, and MDs. We've so far in many of our programs, and most of these are in the scale of somewhere between 2,000 and 5,000 patients at the moment, we've yet to have any of these programs require an MD involvement for any patient. And in fact, to be honest, we're thinking of getting rid of RNs and MDs across the entire platform because the pharmacists are much better at running these algorithms than we will ever be. And to be honest, even the navigators with the right algorithm are more rigorous in many ways than the average physician, where the variability is just so high that you can't really plan or make any inferences. Ultimately, we're going to try and implement this at massive scale in a platform agnostic fashion. But the most important things to know, I think, are you can do this for any disease. These are the first few that we've picked. This pilot is finished. This pilot is 2/3 of the way through. This pilot is finished. And these 4 pilots are actively in progress. The most important thing about all of this is that at the end of the day, the things that are useful are personal contact, and then what you actually collect in the return cycle. You can collect either high-value transactional data, so transactions based around medical, biological phenomena, not around billing phenomena, and then thinking about how we integrate new biologic data streams. Redefining disease also redefines relationships. So we've done this in partnership with, and each of these pilots has been done with a different partner. Payers, PBMs, pharmacy benefit managers, large pharma, technology companies, retail companies, and even the federal government. And you can see that everybody has a different reason to participate. For payers, they're just trying to contain cost. It turns out so actually are pharma and biotech. They get much more bang for their buck if the drug gets implemented at the right level in the first 6 months than taking 12 to 15 years to get to implementation. And in fact, one of the best things about this entire program is that ultimately what we think we're doing is building a consortium around this, and the federal government is actually most interested in participating in this. This is CMS, around value attribution, trying to identify which of the interventions are actually having a major effect. The scary thing about a lot of this is that many of these partners are much further along in thinking about redesign of healthcare than we ever are. If you want to truly be frightened, look at large retail chains and understand that they see healthcare as the single most untapped part of the economy. And they're coming after it in real time with massive investments of cash. One of the retail chains that we spoke to spent $10 billion this year on building out preventative pharmacies in 150 stores worldwide so that they can begin to engage patients decades before they ever reach physicians, because they want to own this space. They don't want to leave it up to us. They've waited too long. And ultimately, I think they have much better global care models than we do. So ultimately, I think what we need to do is to move biology to the clinic, to use innovation to drive what we already know, but also to build a much more transparent and biologically relevant set of data streams to come back into translation. One of the most interesting things about a lot of this is you can begin to do very fundamental science in the clinic if you actually have rigorously controlled parameters. I think you can probably tell that I believe that we're too late in getting into this. And in fact, the real reason that it will happen this time and not for the last 30 years is the fact that people have stopped waiting for us to do it ourselves. Medicine has become part of the problem. Most of these companies that I referred to are already in the game and are thinking about taking over large parts of care. There are at least 2 tech companies I know of who think that they will be able to accrue somewhere around 50% of all diabetics next year. Not 2019, 2018, not 2030, 2018. And so I think that's part of what we have to overcome, is that essentially all of this is going to go away. That if we don't accommodate to totally different revenue models, we are completely lost. One of the most frightening things was the retail chains are thinking about subscription, where they couple legacy loyalty cards for groceries to healthcare and prevention, because they've built assays to measure risk that don't require a blood sample. They require only a little bit of behavioral analysis and a couple of digital images from the cash register. That's all you need in order to identify who's going to end up with coronary disease or heart failure or diabetes. So in summary, I think the central challenges in medicine are related to disease information content. We don't need new diseases, we just need better data, new phenotypes that complement existing data and overcome what is actually an embarrassing lack of comprehensiveness. We've sort of focused, most of the things that we measure today, Osler would recognize, and that I think is actually a testament to just how tradition-bound we are. We need systematic approaches to getting the right information content, newer, earlier, orthogonal, more granular data. We don't need 60 diastolic dysfunction parameters. We need one that actually tells us something about the underlying biology of the diastolic function. We need to eliminate non-biological silos. We have to have structured perturbations. Those are the only things that allow you to translate across scales. And then we need to basically do this actively rather than having it happen serendipitously or by our competitors outside organized medicine. And ultimately, this brings together care and discovery. And if we're really going to design learning health systems, we can't just digitize the current incredibly dysfunctional health systems. We need to start from scratch. So thank you for your attention. And just to point out a few of the people who have contributed, this is my team in our phenotype discovery area. This is the folks who are on the AHA Google AstraZeneca project led by Stan Shaw. Then these are our implementation people, and then support from Google and from the Harvard system. And these are my other funders. Thank you for your attention.
Questions, please. First of all, congratulations on the award. I guess you had hundreds of people competing with you. So that's pretty impressive. Secondly, whatever happened to your Scottish brogue?
So I think it's absolutely spot on. My wife thinks I'm unintelligible because I sound too Scottish, and my parents think I'm unintelligible because I sound too American. So it's perfectly balanced.
Now that I have the microphone, I want to ask a research question. It's about the biology of aging, not about old people. So where, if at all, are you going to be studying the impact of the biology of aging on these cardiac illnesses?
So I think you're absolutely right. A lot of this, what we've done is study age, or we've studied disease, and we haven't thought about the whole thing mapping into a spectrum. And I think part of that is it gets to the original, the tools that we have built to collect information essentially depend on the patient showing up. And what we need are systems that actually allow us to collect trajectories. Because it's actually the aging, not age, that's the important thing. And so I think all of the tools that we're developing are going to be developed in a way that allows you to look at them longitudinally as well as cross-sectionally. And I think that's something that really has to be done. We don't really understand what the biometrics of coronary disease are. We understand maybe you could think of carotid IMT as one metric that we look at longitudinally, but again, that hasn't really made it into clinical practice. The clinical billing is complete, and the clinical interventions are completely based on symptoms. And until we move beyond symptoms, not that symptoms are bad, I actually think symptoms are really good. We haven't built any classification of symptoms in any meaningful way. My chest pain, my 10 out of 10 chest pain is the same as your 2 out of 10 chest pain. But we've not really looked at ways that we could normalize that type of data. So what I'm really saying is better and more granular data collected over time give you access into trajectory instead of just the endpoints. And I think that will actually tell us a lot about what are the factors that change the way in which your nutrition interacts with your aging. How does exercise change biology in real time? None of those are things that I believe we've really looked at systematically. And all of this will become, I think, accessible, not just through work we're doing, but through the way that everybody is building these types of tools. My only concern is that we've tended to go after the low-hanging fruit to the point where people will actually believe that heart rate turns out to be an important predictor of lots of things. Now it is, but it's only an important predictor at one time point in a cross-sectional analysis when you have a ton of other data. We need to move beyond simple wearables and actually move biology into the community. And until we do that, I think we're going to end up with the same answers that we've always had.
There's been a lot of concern about the lack of an ontologic backbone for the recording of human phenotypes. Human phenotype ontology is one of the initiatives to address this, and maybe be interested in hearing what type of ontologic backbone you have for the phenotypes and whether or not those ontologies have been published.
So there are actually 3 or 4 separate human phenotype ontologies. The one that we've worked with is HPO. Peter Robinson, actually who just moved to the Jackson Labs, has been one of the people who has driven that ontology in humans and now is moving it actually to model organisms. The problem with most of the ontologies is they're completely based on legacy phenotypes, on things that we've measured for a long time. What we believe we need to do, and I think you're 100% right, is build an ontology that's based on cell biology or on some other factors that actually stratify disease. So instead of looking at heart failure as EF, it's actually a combination of EF, the systemic effects of heart failure, the underlying cell biology. Is it a peroxisome defect? Is it a cytoskeletal defect? Is it a ion channel defect? Is it a mitochondrial defect? Those things are all accessible. We've just never bothered to try and measure them in people. Everything is essentially grandfathered in from about the 1950s.
So are you planning to recommend to HPO that they modify their ontology?
We're doing all of this in conjunction with HPO. And in fact, we don't want to presume to drive how the field operates. I think what needs to happen is there need to be standardized measurements. I mean, there's a fantastic study in the literature looking at, for example, machine learning interpretation of MRIs. And the single most prominent signal was which MRI machine was used and who the operator was. Because the protocols vary so much between individuals that there's almost you essentially eradicate most of the meaningful biological information by not harmonizing across even the existing phenotypes. So yes, you're 100% right, we need a rigorous ontology. 2, that ontology has to come from some underlying biological knowledge. I think that will take a while to actually evolve. But there are 3 or 4 very robust efforts in particularly in the model organism world and at the NIH to try and drive this across the finish line.
Yeah, I'm very impressed with the work that you've done, obviously, and the different diseases that you say that you have trials going on. Most of my patients have all of those diseases.
Yes.
So how are you planning to do this for people who have multiple diseases?
So the biggest problem with all of this, so I actually started working on this in probably about 2007, and I realized there's no way of getting it funded. And the other problem is that, as you can tell, you can't show up with a minimally viable product in healthcare. It has to work day one. So the things that we decided we had to align all of this around are things that doctors should not be doing and do not want to be doing and are not very good at doing. And then align it with funding from sources that have a vested interest in changing thin slices of this. So we started off with lipids based on PCSK9 inhibitors. We built a consortium of companies that actually have PCSK9 inhibitors to fund our initial pilot. We then realized, obviously, not that we hadn't realized it before, that if you're measuring LDL about 2 years later, about a third of your people have hypertension. So then we layered in a hypertension program on top of that. And then prediabetes is the next thing, so we layered in a prediabetes program on top of that. I think the only way to do this is in sort of what we are calling disease management or risk factor management as a service. So what we've done is actually say to the primary care doctors, what do you want to have happen here? Make sure that we don't take care away from them, but just get it done. So a great example would be we took, the first pilot we did was 1,000 patients, all with a major insurer in Massachusetts, basically to manage their lipids. We took 1,000 people who were not at goal a year after their index event, so this is secondary prevention, definitive indications, heart attack or stroke, ST elevation MI or stroke, not just sort of a biomarker leak, but the real deal. And 20% of those people had never had a statin prescription written. So just simply by getting people who should have been on a statin, we reduced the cost to the insurer enough that they could afford to pay anybody that needed a PCSK9 inhibitor to get it. The second thing that we did, we showed very quickly that these people had, on average, been 9 months or longer without being at goal. And we had 95% of the people at goal within 4.5, 5 weeks. Just with essentially a series of phone calls. And the reason is we're not waiting for another appointment. We're not waiting for another lab test. We're actually escalating to objectively defined goals in the short term. We got rid of specialty pharmacy. That was the biggest saving in the whole system, apart from getting rid of the doctors. So we basically said to the company, we will use PCSK9 in this definition of statin intolerance or this definition of risk. And when the companies and the payers agree on quantitative outcomes, we end up just being the honest broker. So a lot of this is actually just doing what we know already works and getting it done. And doing it in small slices that essentially take little pieces from the current format. And ultimately what we're doing, in fact, we're just about to start putting together the plans to scale this to 50,000 patients in 2 separate locations, one here and one in Europe, where we're actually bringing all of the streams together into a single platform. But you're 100% right. If you have one, you have all of them, and you need to build a system that works for all of them.
Let's have a last question from Mike, please.
So I think that the work is important, and I hope that somehow you get the funding required to continue. But you pointed out that what you really want to do with the disease is learn who's susceptible 20 to 40 years before they actually develop the disease. And you can set certain goals with information that we have right now, but it's going to take 20 to 40 years before you know whether your goal was the correct goal. Do you have some way of assessing long before that occurs?
So, excellent point. So you're 100% right. So what we decided we needed to do, so the other thing, before I sort of explain exactly what I mean, so you can't get anybody to pay for this. So if you take something like this to, let's say, I don't know, CVS Caremark, they will tell you they make no money, zero money, implementing a pharmacy benefit plan. They make all their money from foot traffic through the pharmacy, people buying magazines and toothpaste and stuff like that. So you have to go into this knowing that there is no model where the healthcare system makes money off it. It saves money on it. What we actually think we can do is make money off the research side. So that's our monetization plan for us. And I told you at the start, we make 5 times as much from research as we do from clinical care. And we have a pretty big clinical cardiology division. But in terms of professional reimbursement, 5x from the research. So I need to do this just to keep our current division afloat. But the crux of this is you're absolutely right. What you need to do is you need to work at both ends towards the middle. So we're actually doing exactly that. So the tools that you use in teenagers and in children turn out to be tools that later on are actually quite useful for stratifying early disease. We believe. We've already got a couple of these. So for example, I can tell you whether you're responding to statins based on some skin parameters. I know that already. There's some other things that are actually quite interesting that come out. And we're not focused on skin conductance alone. It was just the first thing we tested. But so for example, atrial fibrillation, if you are genetically predisposed to atrial fibrillation, you have dramatically different lateralization of your skin conductance parameters. In fact, every electrophysiologic phenomenon in your body is hyperlateralized. And if you're not at risk, essentially it's symmetric perfectly. So there are lots of things that we discovered very early on in genetically susceptible individuals that we're already moving into adults with the disease to try and identify, is there a different stroke risk? Is there a different risk of recurrence? Is there a different risk of response to ablation or whatever? So all I'm really saying is I think the fundamental stuff at the start will feed quickly into the clinical care at the end once we've actually identified the right pathways. And we need to do both in order to essentially hedge and to co-fund. So I can get funding for the basic science at the moment, and I can save money on the clinical side at the moment. If I put them together, I have a business model that works, at least for me, or for us as a division. I think it'll work for academic medicine in general, but you're right, it's not an easy transition to go from our current 18th century model where people show up to one where you're managing a network of 100 million, 200 million patients. And I can tell you that the retailers think they're going to be managing 900 million patients. One of the retail chains we spoke to has 900 million people, individuals, enter their store every month globally. And they're completely content to manage that and are not worried about the fact that we have healthcare IT systems that look the way their supply chain management looked in 1986.
I think we need to thank Dr. MacRae.